The next speaker, Professor Shrouk Moataz. Professor Shrouk Moataz, Professor of Pediatrics and Pediatric Nutrition.
Cairo lecturer يا دكتور.
lecturer؟ طب بص
بشرة خير يا حنان، هنبارك لها قريب.
ربنا يخليك يا دكتور.
بس على بروفيسور على طول، مفيش اسيستنت بروفيسور. ماشي.
Dr. Shrouk will talk about something very important. Actually, I consider it as lethal complications that can happen in the ICU, refeeding syndrome. تفضلي دكتورة شروق.
Thank you very much, Professor Dr. Hanan. It's a great honor and pleasure to me to be invited and hosted today by my greatly esteemed professors in such a unique scientific event. I will try to do my best to make the presentation simplified and applicable for all my colleagues. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. First of all, we need to know the pathogenesis or the meaning of what's named the Nutritional Recovery Syndrome, which is the new name of Refeeding Syndrome. The principle simply depends on rapid shift from the catabolic state from which the patient in the intensive care is usually suffering with very high levels of anti-insulin hormones, shifting him rapidly to anabolism with a rapid surge of insulin secretion. This graph shows us that under stress, there is very high rate of glycogenolysis in the liver with rapid release of proteins, fat, minerals, electrolytes from the cell. When we make very rapid refeeding with gush of calories and proteins to the patient, we shift him to anabolism. This provoke insulin secretion, which turn on the cell engine to make very rapid protein and glycogen synthesis, and this need actually substrates. So this lead to increased glucose uptake, increased utilization of thiamine, increased uptake of electrolytes, particularly potassium, magnesium, and phosphorus. These all lead subsequently to decreased serum levels with fatal complications like hypokalemia, hypomagnesemia, hypophosphatemia, thiamine deficiency, salt and water retention, and edema. Refeeding syndrome is a fatal but still a preventable complication that typically occurs during the first week of nutritional rehabilitation. A physician should anticipate and keep very high index of suspicion for early diagnosis and management. We'll discuss now the ASPEN consensus criteria, which is published this year about risk assessment. We need to know how to pick up the patient who is at risk for refeeding syndrome. We'll try to make it very easy tips for our dear colleagues to be easily utilized. I try to make it easily memorized by making it initials like A, B, C, D, and E. A letter stands for anthropometry. What are the anthropometric measurements we need to measure? First, we need to take the length, and we need to take the weight, and to plot these measurements on the weight for length z-scores if the child is less than 2 years, and to plot it on BMI for age z-scores if the child is more than 2 years. The third anthropometric parameter, which is very important, is the mid-upper arm circumference, and to make its interpretation, if the child is less than 5 years, the WHO have set a set point, which is 12.5 centimeter, below which the patient is classified to be suffering from malnutrition. But if the patient is older than 5 years, we need to plot the measurement on the mid-upper arm circumference for age z-scores charts. This is the weight for length chart for boys. And this is the BMI chart for age for boys. And we have all these charts present on the WHO website for free download and printing. The mid-upper arms measurement actually is a very simple procedure and is very informative as well. We make it simply by taking a point midway in the left arm, midway between the acromion and olecranon process, while the arm is put in the right angle. As we previously mentioned, that the cutoff point is 12.5 for children less than 5 years. When it's more than 11.5, it's classified as moderate undernutrition. If it's less than 11.5, it's classified as severe undernutrition. This paper was published the last year as a collaboration between pediatric ICU and clinical nutrition teams at Cairo University about the effect of some sort of high-fat dietary modification and the nutritional status on the outcome of critically ill ventilated children. Among the results we obtained was the great importance of the mid-upper arm circumference. We found that this anthropometric parameter was one of the, or actually the strongest predictor of the final intensive care outcome. And it's always advisable to make all the anthropometric parameters initially upon pediatric ICU admission, as professors has previously mentioned. Now we come to interpret the anthropometric measurements we have taken. The ASPEN classified the patient into 3 categories: the category with mild risk and moderate risk and significant risk, according to the interpretation of weight for length or BMI for age z-scores. Mild risk, they consider it from -1 to -1.9. Which is a change from baseline. Moderate risk is interpreted when the measurement lies between -2 and -2.9, which is a change from baseline. And if the measurement is -3 or greater, that is a change from baseline. B, in the risk assessment criteria, it stands for bad energy intake. We need to make a thorough history taking to know how long the child was deprived from taking his proper nutrition, and actually the amount that was previously taken. Mild risk is put in, or the patient is classified as having mild risk when he does not take a proper intake for 3 to 5 consecutive days, or taking less than 70% of estimated needs. When the intake is very poor for 5 to 7 days, or the intake is less than 70%, the patient is classified as moderate risk. Significant risk is stated when the patient has poor intake for more than 7 consecutive days. C letter stands for associated comorbidities. We need to know what are the risk factors that is associated with the poor anthropometric parameters and the bad intake that makes the patient at high risk for refeeding syndrome. Dysphagia and esophageal dysmotility, or any form of eosinophilic gastrointestinal problems, previous history of eating disorders, failure to thrive or victims of neglect, protracted vomiting and prolonged fasting, major stressors or surgery without nutrition for prolonged periods of time, malabsorptive states like short bowel syndrome, Crohn's disease, cystic fibrosis, pyloric stenosis, and pancreatic insufficiency, definitely oncology patients, advanced neurological impairment, post-operative patients with complication, and protein energy malnutrition. Letter D stands for decreased subcutaneous fat and muscle mass. Wasting is definitely a risk factor for refeeding syndrome. We can make it by clinical assessment of the grade of wasting into mild, moderate, or severe. And also we can interpret the mid-upper arm circumference, as we previously mentioned, to know the degree of loss of subcutaneous fat. Letter E stands for electrolyte disturbance, and this is a very, very important point to be closely monitored and assessed in patients at high risk. It should be performed pre-feeding, definitely. I know that all patients admitted to the pediatric ICU should undergo electrolyte measurements. Any abnormal pre-feeding serum potassium, phosphorus, or magnesium concentrations, it can be classified into mild, moderate, and significant risk according to the degree of abnormality, whether it's mild, moderate, or significantly decreased. This is the table that involves all the previously mentioned assessment criteria collected together. Then we come to the medical complications. Actually, most of the complications are fatal ones, and when we find that the patient is high risk, according to the previously mentioned criteria, we should keep re-evaluating and anticipating to prevent the occurrence of the coming complications. it's a multi-organ system involvement, and the base of this, as we previously mentioned, is the fluid and electrolyte shift and thiamine deficiency. Complications can be reduced by proactively and frequently checking electrolytes, particularly phosphorus, along with aggressive correction of the abnormalities. First, the cardiac complications. The patient in the intensive care who develop the refeeding syndrome may undergo unexplained or show manifestations of unexplained heart failure, and the base usually is fatal arrhythmias because of decreased electrolytes, or beriberi due to thiamine deficiency, or cardiac overload due to salt and water retention. Respiratory complications, also patient may exhibit unexplained respiratory failure mostly due to respiratory muscle and diaphragmatic paralysis, primarily caused by hypophosphatemia and general wasting. The neurological complications as well might occur in the form of tremors, lethargy, fatigue, mostly due to decreased electrolytes, or patient may develop some sort of encephalopathy presenting as seizures and coma due to decreased thiamine. Hepatic and gastrointestinal complications mostly involve some sort of mild to moderate transaminitis with mild elevation of liver enzymes during the first weeks of refeeding. Mostly the cause is excessive calories causing glucose overfeeding with subsequent hepatic steatosis. There is a coincidence which is not directly related to the refeeding itself, but it's commonly encountered with feeding initiation, which is diarrhea during the first few weeks of feeding initiation, mostly occurring due to villus atrophy that results from chronic malnutrition. How we can avoid refeeding syndrome? As we previously mentioned, that it's a preventable syndrome. So we need to know how to prevent it. The principle of prevention is to avoid a rapid gush of calories and proteins. However, as previously mentioned, that there is poor consensus about feeding rates, how much we need to start of the caloric and protein requirements, how much we need to advance. So it's better to make an individualized refeeding approach according to every patient condition. And when initiating and advancing feeds, we need to consider changes in serum electrolytes and cardiac rhythm to avoid this fatal complication. Thiamine supplementation before feeding is very important because the evidence suggests we need to prescribe 100 to 300 milligrams per day of oral thiamine, or 50 to 100 milligram IV or intramuscular for a total of 3 days. And it's better to give the first dose before feeding initiation. Thiamine replacement should be continued for 7 to 10 days for patients suspected to have vernix encephalopathy and for confirmed cases of thiamine deficiency. Actually, these are very rare scenarios. Those are two products. I prefer to put them in order to help my colleagues who take shifts in the intensive care to know both products and prescribe them immediately, not to waste time searching for the product which contains the appropriate amount of thiamine, and I have no conflict of interest. When to start feeding, actually the data are conflicting. Some reports advise to refeed and correct electrolyte abnormalities while refeeding. Some others prefer to treat electrolyte abnormalities before feeding initiation. Actually, to correct the electrolyte abnormalities, we don't need more than 12 to 24 hours. So this is not contradictory to the previously mentioned one. Some papers suggest prophylactic phosphorus supplementation, and I think this aspect in particular needs advanced research, especially in our centers. How to start and advance feeding? We need to prescribe initial amount of calories very close to the resting energy expenditure. And professors previously mentioned the way we can prescribe or determine the amount of caloric requirements. And some papers advise that we need to monitor CRP values. And when the CRP decreases less than 2 milligrams per deciliter, we can advance at 20 to 25% of goals estimated requirements per 24 to 40 hours period according to the clinical and laboratory evaluation. The take-home messages that refeeding syndrome is a potentially fatal complication. Hypophosphatemia and thiamine deficiency cause multi-system complications. Severe wasting, comorbidities, and baseline electrolyte abnormalities are high-risk factors. Start with basic caloric requirements and avoid very rapid increase. Close monitoring of clinical and biochemical markers is mandatory during the first week of refeeding. Anticipation and vigorous correction of electrolyte abnormalities is life-saving, and prevention equals proactive management. And I always remind all my colleagues in the ICU that we need always to keep eyes on phosphorus, anticipate and vigorously correct any form of hypophosphatemia. And thank you very much.
شكرا يا دكتورة شروق. الحقيقة محاضرة أكتر من رائعة. أخذتي موضوع من أهم المواضيع الحقيقة في الانتنسيف كير وفي الفيدنج بتاعت الأطفال عامة السيفيرلي مالنارشت أو اللي في كريتيكال كونديشن. موضوع الحقيقة very 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 important والحقيقة قدمتيه كويس قوي. وبشرة خير بقى حنان رقتك يا شروق خلاص احنا هنكلم كل الدنيا خلاص. دكتورة حنان كلمتها ما نقدرش نرجعها يعني خلاص. يعني ربنا يبارك لك وان شاء الله الدسكشن هتبقى في الاخر باذن الله
ان شاء الله.
شكرا يا دكتورة شروق.
شكرا لحضراتكم، شكرا جزيلا.
شكرا يا دكتورة شروق. ودلوقتي يسعدني ويشرفني ان انا اقدم زميلي العزيز بروفيسور دكتور ايهاب خيري، the head of pediatric